Again, again, I want to make sure everybody knows and tell to your friends to put in the calendar September 5 to 8 in Rome, the Eternal City, International Congress of Shoulder and Elbow Surgery. It's going to be great, and it will be great to have you there. My talk will be a little panicking here, but I don't mind to be controversial. This fracture, this solution. Is this the only way? My question. Reverse shoulder arthroplasty for proximal humeral fractures. Let me give you my thoughts on this subject. Here again, a fracture and a reverse. Is this the only way? Does it make sense? I'm not trying to be aggressive with the red color. I'm just calling attention to this. It seems that it's too aggressive, but it's not. Listen, are we going too fast? We started 100 years ago with these fractures, all conservative. This is gesso thoraco-brachial, as we call in Brazil. Then some pins started, some screws. In the 50s, 60s, and 70s, 80s, Hemi, led by my professor, Charles Neer. Then Hemi was out, and plates were for almost everything. And finally, reverse. Well, I like this slide. It's not my slide. Change is the only constant. I cannot say whether things will get better if we change. What I can say is that they must change if they are to get better. This was spoken in the ISACOS meeting in Cancun, in the presidential speech. I like this very much. I want to ask you what you would do in this fracture. This or this? We will see later. What about in this fracture? Would you do this or this? Let's talk about this later on. So, first remember, a plate costs about 1,000. I'm talking about US money. A Hemi, 3,000. And a reverse, 7,000. And in Brazil, Michelle is here, our government is responsible for 75% of all treatments. 20% comes from insurance companies and only 5% private. So money matters for all these three. So how much I want to spend for a treatment? This is the thing to be considered here. It's not the same. Let me see if I here, yes, I can go here. This is a very common fracture in the elderly, and we decided in this case to do a plate, which is not an indication that everyone agrees, but it was solid, intact, 73 years old. This is another one almost the same, and we have decided to go ahead and do a Hemi, and the head is here behind the diaphysis. So bone grafting from the head between the tuberosities and diaphysis is very important. And of course, the best you can do in suturing the tuberosities. This is the key point for the success of this procedure. When you have a healed greater tuberosity, these are the results you will achieve most of the time. Not every time, but most of the time. Greater tuberosity. Here are the 50% of the complication rates in the Hemi. The greater tuberosity may be malpositioned, migrated, or non-united, according to Boileau. Too high or too posterior. So it seems that the greater tuberosity, it's the main cause of the bad results in Hemi. So we have to look at that. This is a patient, 78 years old, that had a Hemi, but gosh, see this? It's dislocated anteriorly. Too much anteversion, and it's not the same patient, but this is what happens. Anterosuperior escape. Anterosuperior escape, you cannot raise the arm. So this case had to be revised. And that was a tough procedure. Osteotomy of the humerus, take it all out, and we changed to a reverse. And fortunately, here is the patient doing great after this procedure. So, we are not safe from complications. They can occur. And then the literature that we keep an eye on mention the advantage of the reverse in the proximal humeral fractures in these past 15 years. Osvandre Lech has mentioned a very elegant article in 2010. Daniel Mollet mentioned in the CESAC meeting 11 years ago, the tuberosity is the key. When the tuberosity is healed, constant score is higher as compared to when it's not healed. And then, this is a French patient, 75 years old, heavy smoker, and a good solution with the Philippe Valenti prosthesis. In 2013, he published that. Also in 2013 came out something very interesting from New Zealand. Craig Ball, my friend, made a very nice study comparing 55 reverse and 300 Hemi. No difference in 6 months. No difference in mortality or revision in his experience. However, reverse is better in 5 years of follow-up. Then, 2014, in the ACES meeting, 15 papers, a meta-analysis, reverse is better in elevation and outcomes. Hemi is better in external rotation, and complication rate was similar in both groups. We come to 2020, a very nice study showing that reverse is better than plate in elderly. However, a better paper came 1 year after, and I like this paper here. 8 years seems to be the limit for expectation in pain and satisfaction. And look at that. Below 8 years, reverse is better than Hemi. Below 80, reverse is better than Hemi. However, above 80, the very old lady or man, reverse is equal Hemi. It doesn't make difference in pain and satisfaction. It does make difference in price because it's more than double. So, makes sense, this paper. I like very much. And this is a tremendous paper. I like a lot because it comes from Buddy Savoy, the current president of American Academy. They review, 160,000 patients above 65 years. They made a study in epidemics, of course. 83% were conservative treatment, and only 17% surgical of all types. Plate, Hemi, reverse, pins, nailing, everything. Well, look, this is important. Reverse, much more than Hemi in 2019. And the turning point was 2014. So about 8 years ago, it was a turning point where the Hemi started growing as compared, reverse started growing as compared to Hemi in the United States. And one more thing, the last decade, which was the tendency, the trending. Number one, conservative treatment has more indication nowadays than 10 years ago. This is new for me. I had no idea of that. So it's very good, very good. Hemi decreased 81%. And reverse, guess what? Increased almost 2,000%. This is amazing. So this is how the facts are stated for us. In proximal humerus fracture, CT is mandatory because this is not an emergency. You can see the head split or not. You can understand where the tuberosities are, the osteoporosis, the thickness of the bone, the rotator cuff integrity. So CT is important. I like this slide from Pascal. He sent it to me. You think of reverse for fractures when the patient is old, osteopenic, has difficulties of healing, diabetes or smoker, and maybe in dementia or early dementia, has osteoporosis or a bad cuff, rotator cuff. And here is the film he sent to me. He was very kind. Take the long head of the biceps off, cut it, take the head out, and then make your very nice spacing sutures in the lesser tuberosity, like it is here. He's passing in the lesser tuberosity. Now he cuts the, Osama, he cuts the supraspinatus, you see? We discussed that. And then he inserts the glenoid component. Any method has similar procedures. And then he goes and he will do the humeral side procedure. And he finished that making a very nice tightening of the greater and the lesser tuberosity. See, he is measuring the height now, implanting the long stem, because this is a fracture, it's not a short stem. Inlay, as you know. And here comes a very important step of this procedure. Tightening, suturing both tuberosities. Very strong. And this is a technique that is published by Pascal. And I thank Pascal again for sending me this very nice video. He's suturing lesser and greater tuberosity with no supraspinatus in there. You see? We were discussing with Osama a minute ago. So this is, and so the reverse restore forward elevation, but not external rotation. So when you do a reverse for fracture, please repair the greater and the lesser tuberosity. Then you will have a better function. This is another case. We prefer a reverse. And all these steps, how you approach, I do through a deltopectoral, the height of the prosthesis, the tension, retroversion, and suture of the tuberosities. All important steps in order to have in this lady this result here. She doesn't look happy, but she's fine. I always ask the patients to smile, but I couldn't get from this lady. So, I need that. Where is it? I need the So, all what I said, is this the only way? Reverse for fractures? Does it make sense? Well, make your own decisions. Make your own decisions. Conservative treatment is more common today than was 10 years ago. This is new for me. Plate and hem is still in the armamentarium. Reverse needs to learn first. Reverse needs tuberosity reattachment, as you think that is just throw the reverse and it will work out well. And reverse leads to better outcomes almost without physio. This makes a big difference. And finally, it's the only way? No, it's not for me. I have many choices when I see a fracture. It's still almost at the top of my profession. It's difficult to decide. Every case has to be discussed. Experience counts for the decision. Usual disagreement among the experts we can find here in this room, for example. And great tool for your armamentarium. Thank you and sorry for the delay.